Today, breast topic. If we subdivide breast topic, like yesterday we subdivided, right? Urology, kidney, ureter, bladder, prostate, urethra, like that. If we subdivide, there are 4 major subheadings from where questions can be asked. Surgical anatomy, sir, your class is good. Kindly go slow. Okay. Somebody was asking to go slow. Okay. So, okay, we'll go slow. In breast, there are 4 topics: surgical anatomy, investigations, benign breast diseases, and cancer breast. Out of this, importance wise, cancer breast is very, very important. Okay, so we will first talk about cancer breast in detail, and the other things which we can discuss by question answer pattern. Some questions are there, so which will cover the entire topics. Okay, so surgical anatomy, investigations, benign breast, and cancer breast. We'll discuss with cancer breast in the first. Again, in breast cancer, if we take breast cancer topic, there are 5 subheads like investigations and triple assessment. This is very important. Investigation and triple assessment asked many times. Etiology and risk factors of breast cancer, pathology, staging, and treatment. Okay, so these are the side headings which will go. So each will have its own questions. So we'll discuss in detail about each of them. So see this was asked in December FMG exam. Which patient has better prognosis in breast cancer? Which patient has better prognosis in breast cancer? This question was asked. I think you all have seen the previous questions. You might have gone through this question. Actually, it was asked in pathology section. Okay, so which patient has better prognosis in breast cancer? Because this is a new type of question, because till then we'll send it to biopsy. We'll take a small biopsy tissue and we'll send it to biopsy. So what is that known as? What is that biopsy known as? Breast biopsy. We'll send it for what is HPE?
Histopathology examination.
Histopathological examination. We'll take a small sample of breast tissue and we'll send it to histopathological examination. What does this mean? Histopathological examination. Histo means histo. The meaning of histo is
tissues.
tissue. Pathological, that is examination. Pathological is to find out any underlying pathology, and it is a pathological examination. We'll do that in tissue pathological examination. Till then, we were asked only about histopathological examination. But in recent guidelines, they changed this histopathological to histoimmunological examination also. Okay, so this is done and this is done separately. This is a histoimmunological or molecular classification, we call it as. They have asked this question, so we'll discuss this also. So the same question, the most common histoimmunological type of breast cancer, the answer is luminal A. I'll discuss this in detail. So they may ask you this time this question. So last time it was there. Which patient has better prognosis? Luminal A. And most common also is luminal A. So they may ask you this time. This question they may ask you. Okay. So we'll discuss in detail. So from here, this topic we'll discuss. I'll put forward the question. We'll discuss the concept and then we'll discuss the answer. Suppose see this question. Triple assessment of carcinoma breast. In investigations, first we'll discuss investigations for CA breast. Investigations. Okay. In investigations, triple assessment. One word summarizes. If you tell even in your Viva voice after PGs, if you tell investigations, you just tell triple assessment, you are passed. So what is this triple assessment? What is the so much importance of triple assessment? And triple assessment of CA breast includes what? See the options and take 2 minutes and just tell me what is the answer. Triple assessment is history, clinical examination, and mammogram, history, clinical examination, and FNAC, ultrasound mammogram and FNAC, clinical examination, mammogram and FNAC.
Sir,
Yes, also.
Is it D?
Okay, option D.
Option A. Okay.
Option A, okay.
Option D, sir.
Option D, yeah, option D. See here. History and clinical examination both fall under one category. Triple assessment. I will talk about 3 categories. Okay. So history and examination will fall under one category. Pathology will fall under one category. Radiology will fall under one category. See here in history, clinical examination, this is 1. Mammogram is radiology. 2. History, clinical examination 1. FNAC is pathology 2. Ultrasound mammogram, both are radiology. 1. FNAC, pathology. 2. But see, in this option, clinical examination is there. 1. Mammogram, radiological investigation is there. 2. FNAC, pathological investigation is there. 3. So all these 3 are there. So this is the correct option. Okay. So what is triple assessment? Triple assessment is clinical, pathological, and radiological. CPR. Okay, cardiopulmonary resuscitation. That is the code. Clinical, pathological, and radiological. Clinical. What is clinical? You have to identify the history. You have to take the proper history of the patient, and you have to examine physically. Physical examination. Both are covered under clinical assessment. History and physical examination. ACE is written, but history. This is history and examination. And then pathology. Pathology is you take a small sample of tissue. Okay, you take a small sample of tissue and send it to the pathologist. So either you can do a FNAC, or you can do a core cut biopsy. We'll discuss what is FNAC, what is core cut, we'll discuss. And then send it to radiology. What is radiology? You do an ultrasound and you will do a mammogram. Both these investigations can be done radiology wise. So triple assessment of CA breast will include clinical exam, mammo, and FNAC. Is this clear?
Yes, sir.
Yeah. So triple assessment of CA breast, you have done triple assessment of CA breast. What is the chance of finding the correct answer? That is finding malignancy. Option 90, 95, 99, 99.9. So if you done triple assessment correctly, what is the chance of finding the malignancy? Any guess? Take a guess, no problem.
99.9.
Yeah, see here, this is Bailey. This table is taken from Bailey. In Bailey, they have mentioned it. 99.9% of the times you will be correct if you do triple assessment properly. Okay. Okay. Then okay. So before we move on, the order CPR, I told you, which is to be done first, which is to be done second, which is to be done third.
Clinical.
Yeah, sorry.
First one is clinical.
Yeah, obviously. The
So
first
is
one
it
will
the
be clinical
same
photo.
order? Same
Yeah.
order as option
Pathological,
D.
then pathological.
Clinical exam, mammogram, and FNAC. Yeah, same option. And very good. It is like same. This option only. Like first is clinical, then radiology, then pathology. Okay. Why not? Clinical is always first. No doubt in that. We have to take a history. We have to examine. Then only we'll send it to pathologist or radiologist. So clinical examination is number 1. Okay. Then after clinical, is it radiology or pathology? Or after clinical, is it pathology and radiology?
Before
Radiology and then
radiology, we can do
pathology.
invasive procedures. So
Radiology and pathology. Why not this one? This is wrong. After clinical, you should not send to pathology directly. Why not? Why not like that?
because we have to confirm it via another source as mammogram by that scoring.
You can confirm what is there. Okay, no problem. You will take a biopsy and you will send it to radiologist. Both are confirmed.
Pathology is more
That will take the
specific, right, sir? So you do that and in the end, right?
Pathologies to find cells.
To avoid metastasis of the
Radio is to confirm the.
Okay.
It is invasive procedure.
Yeah, somebody was telling it's an invasive procedure. See, this is the breast lesion, suppose. And if you put a needle, FNAC is putting a needle, or if you put some core cut, if you take a chunk of tissue, what will happen? There will be, you are piercing it. It is an invasive procedure. Once you go inside, what will happen? You are going into the mass. You are taking a small chunk of tissue. What is bound to happen?
spread.
No, not spread so immediately, but before that,
Bleeding.
yeah. So there will be bleeding inside. So it will form a hematoma. it will form artifact. Okay, it will form an artifact inside. So a small lesion. You will again, if you do an ultrasound after this, or you do a mammogram after this, you will be confused with this new thing. Okay, we don't know what is that. Is it a hematoma or is it something else? Okay, so always first do, after clinical examination, do a radiology, like ultrasound or mammo. Either of them you can do. Which one to do, we will discuss. Either of them we have to do, ultrasound or mammo, and then send it to pathology. Okay, clear? To avoid is artifacts, issue of artifacts. Okay, once you put a needle or once you put a biopsy gun into the mass, there will be bleeding, obviously. Yes, no?
Yes,
Yes.
sir.
Yeah, so always first clinical, then radiology, then pathology. Okay, if that is clear, then what is this? Have you seen any time? What is this being done in this?
Mammogram.
Yeah,
Mammogram.
it's a mammogram. It's a mammogram. Mammogram is nothing but it is an X-ray of the breast. It's a mammogram. Okay. And what is this being done here? Procedure. These are all
that-
image-based questions.
is that
Okay, they can
FNAC?
ask you. Yeah, this is an FNAC. FNAC is, what is
Fine
FNAC?
Fine
Fine
needle
Fine needle aspiration
aspiration
cytology.
cytology.
cytology. Very good. So see here, we are putting a small fine needle. We are putting a small needle into the lesion, and we are aspirating the cells. Okay, we'll just, the technique is we'll just put a needle and we will do multiple throws like this, multiple throws, so that the inner cells will be cohesive. We will disrupt the cell barrier, cell junction, and some of the cells can be aspirated. We'll spread them on a slide and we will do an examination. So this is fine needle aspiration cytology. It is only cytology. It is only cytology. Remember, it is not tissue. We'll get only few cells here. Okay. It is cytology. Cytology is examination of cells. Histology is examination of
Tissues.
tissues. Yeah. And what is this here being done?
HPE.
Core cut biopsy.
Cool.
Yeah, this is core cut biopsy. Core cut or core needle biopsy, or also known as through cut biopsy. True cut. It is through cut, but people call it as true cut. True cut. That is, we put a small nick on the tissue skin and we'll put this biopsy gun. This is a biopsy gun here. We'll just put it. We'll get a chunk of tissue in this. Okay, we'll get a chunk of tissue. Yesterday, we in one section I discussed the same thing. With this biopsy gun, we'll take a biopsy. In which cancer we'll take a biopsy with this gun?
Is
Prostate.
it rectal biopsy, sir?
Yeah, prostate. Very good. It is transrectal ultrasound guided prostate biopsy. With the same biopsy gun, we will take a biopsy in that also, prostate also. Okay, we'll get a chunk of tissue there. It's not cells, it is tissue again. Okay. So, the first investigation for tissue sampling, best and diagnostic investigation. See the question framing. The question will frame and the answer will differ. First investigation is mammogram. Okay. If mammogram and ultrasound both are there also, it is mammogram only. Okay. It is better than ultrasound, but most of the times it will not be there. First investigation will be.
In the investigation, actually, the mammogram and ultrasonography differs reason by depending on the age. So, if they are above, if they are less than 35 years, then ultrasonography is preferred, and above that would be, especially depends upon the dense breast. So, ultrasonography for dense breast, and the less one is usually for mammogram.
Yeah, we'll discuss that. When to do which investigation, we'll discuss. So, the first investigation is mammogram. Okay. And the first investigation for tissue sampling, here see that they have asked for tissue sampling, that is pathological investigation. The first investigation is FNAC. Okay. Best and diagnostic biopsy. It is the best investigation. Biopsy. If you take a tissue biopsy, it is the best and diagnostic. So why not first investigation for tissue sampling? Is it FNAC or core cut biopsy? First investigation.
Can it be FNAC, sir?
Which one?
First investigation, like out of the two.
FNAC. Why not core cut? Core cut also is the same, and we are getting more tissue, right? But why not first investigation? If they ask, you have to answer only FNAC. Why not core cut?
Is it because of the amount of sample collected?
No.
Because of the cells and
See, suppose a breast mass comes to me. I'm sitting in my OPD. If a female comes, a 45-year-old female lady comes to the breast with the breast mass, I'll do clinical examination. I'll take a proper history, do clinical examination. Then I'll send her to 45 years. So I'll send her to mammogram. She comes with mammogram. Mammogram is showing a suspicious lesion. So immediately what I'll do is, in my OPD only, I'll just needle I have in my OPD. I'll just put a needle, take some FNAC. If the FNAC is showing malignancy, it is confirmed. Okay. It is a simple investigation. Yesterday also I told you, ultrasound and CT. Which is the first investigation?
Ultrasound.
Why? Because of the ease with which we can use. Ultrasound is available in every nook and corner of India. Okay, so we can easily use it. The same way, FNAC, we can just do it in an OP procedure. Patient will have no pain at all. Okay, just putting a needle inside, and if we get the answer, it is over. Otherwise, we have to take a tissue. We have to ask the pathologist appointment. We have to give local, and then we have to put that biopsy gun inside. We have to take that tissue outside. So it's all a big process. So the first investigation in the question, if they mention, that means they are asking us which is the simplest thing to be done. Okay, which is available everywhere. Got my point?
Yes, okay, sir.
Sorry?
Yes, sir. Okay, sir.
Yeah, good. So here we'll see what are the drawbacks of FNAC. Suppose these are two drawbacks. Invasive, see, FNAC, will we get cells only or tissue? What will get? Only cells or tissue? Only cells will get.
Cytology cells.
It is cytology, so only cells will get. So suppose this is the epithelium. This is the epithelium. This is the basement membrane. Okay. And inside is the stroma. We'll get only the epithelium. Suppose think like that. We'll get only the epithelium. We will not get the basement membrane. We will not. It is only a needle. Okay. So just the needle will stop here. If we put a biopsy gun, it will enter inside. So it cannot differentiate between invasive and in situ lesions. Okay. I'll repeat it one more time. See, there are two types of lesions. Okay, one is invasive and one is in situ. What is in situ means? Carcinoma in situ. You have heard about it. Carcinoma in situ. What does this mean?
Non-invasive.
Non-invasive. That is, it is not invading the basement membrane. It is above the basement membrane only. It is a least type of malignancy. It is a malignant lesion, no doubt. But out of malignancies, it is the least type of. It is the less dangerous type of malignancy. In situ. It is only started here only. It has not breached the basement membrane and went inside. Okay. So this is in situ lesion. So if you do an FNAC, you just get the cells. Okay. You are not getting the tissue. So you can't tell whether it is invasive or in situ lesion. Okay. That is the main drawback of FNAC. Okay. So you cannot tell whether it is a in situ lesion or invasive lesion. That is one. And what is this ERPR? Any idea?
Estrogen receptor. Progesterone receptor.
Progesterone receptor. Yeah. Yesterday also in one cancer we are talking about testosterone. Which cancer is that? Testosterone.
Testicular tumor.
No. Testosterone. So we do an orchidectomy. In which cancer we do an orchidectomy? Bilateral orchidectomy.
Prostatic cancer. So prostatic
cancer. I told you, right? Yesterday we were discussing prostate cancer. Yeah. So in the same way, this cancer is also breast cancer is dependent on estrogen receptors and progesterone receptor, hormone based. So this status of estrogen and progesterone receptors we can get only when we have the tissue inside. With only single cells, we cannot identify the ERPR status. This is one drawback. So these are the two drawbacks of FNAC. So the investigation of choice, if they ask you, investigation of choice for tissue sampling, then it is true cut biopsy. Okay. And gold standard is excisional biopsy. We are not doing gold standard anytime. Excisional biopsy means taking out the whole lesion. That is always the gold standard. But we will do something else. If the malignancy is confirmed, we have to do a mastectomy. We cannot remove only the lesion. We have to do the entire breast lesion, breast tissue. Okay, why we will discuss. Okay, is this clear? Investigations part, pathology part clear. What is FNAC? What is true cut? What is FNAC drawbacks? What is the advantages of true cut? Clear?
Yes, sir.
Yeah.
Yes.
Tell me two advantages of TrueCut.
So we could tell actually if it's invasive or in situ.
One, very good. Then the other one. Same.
On the ER and PR status.
Yeah,
as
ER
well.
and PR status also we can tell with TrueCut biopsy. The disadvantages of FNAC are the advantages of TrueCut. Okay. Then what is the disadvantage of TrueCut?
It could be seeding.
So the hematoma and bleeding and things
Yeah,
like that.
hematoma bleeding, and it's a invasive procedure, right? It's a basically a major invasive procedure. We have to take pathology. We have to take the consent for pathologists. We have to do it. It is a OPD procedure, but daycare procedure. It's a little bit more painful than FNAC. So these are all the drawbacks of TrueCut.
So what was the procedure that you mentioned? Daycare?
It will be a daycare procedure. We have to admit the patient and do it, right? We can't send. FNAC is an OPD procedure.
Okay.
Patient comes, we'll put a needle, we'll take the cells, we can send the patient. But TrueCut biopsy, when we put the TrueCut needle, it will be a little painful. There may be hematoma also. So it will be a daycare procedure. We have to admit her and we'll discharge her in the evening. Okay. This is a detailed drawback for TrueCut biopsy. Okay. Okay. So we'll discuss about mammogram now. So mammogram is nothing but it is an X-ray of the breast. It is taken in two views: craniocaudal view and mediolateral view. Two views: craniocaudal from above below, mediolateral. Two views we will see. Okay. So here the question is: this is the breast. Suppose this is the left breast. There is a small extension. Breast is not round. There is a small extension into the axilla. What is this known as? Axilla. Anybody? Anatomy. The small extension is known as
Tail of Spence.
very good. Axillary tail of Spence. Axillary tail of Spence. Okay. So now tell me, with which view maximum amount of breast tissue can be seen? Is it craniocaudal or mediolateral? Mediolateral or
Mediolateral.
craniocaudal?
Mediolateral.
Obvious. Yes, very good. So this is an important MCQ. They will ask you which view will cover maximum amount of breast tissue. It is always the mediolateral because there is breast tissue extending into the axilla. So it is mediolateral. Okay. So what is the routine screening age of mammogram?
40
40?
above.
40 years.
Yeah. So this is the routine screening age. After 40, if the patient is falling under high risk category like family history or the patient's siblings are having breast cancer or if she is having any hormone replacement therapy, in such cases, we have to do screening mammogram. Okay. From 40 years of age. And yesterday we were discussing about some score, Berard score for COVID. In the same way, there is a Berard score for breast. There is a Berard score for prostate. There is Berard score for thyroid. So Berard score is there. And Berard score of 5. What does this mean? Score 5.
Highly suggestive
Option D.
of malignancy.
Very good. Okay. So we'll see what is the things. Okay. So yeah, craniocaudal, mediolateral. So maximum tissue is there in the axilla. So that is about mammogram. And mammogram categories are there: 1, 2, 3, 4, 5, and 6. Okay. Out of this, 5 is highly suggestive of malignancy. And see here, 1 is negative, not 0. 1 is negative. 0 is we have not identified anything. That is 0. Okay. So don't mark 0. If everything is negative, it is 0. The negative is 1. Benign is 2. Highly chance of malignant is 5. Okay. 3 and 4 are probably benign and probably malignant. 3 is probably benign, 4 is probably malignant, suspicious of malignancy, and 5 is highly suggestive of malignancy. Okay.
So sorry, I can't understand why category 1 is negative. When it's negative, why do you give that number?
It is negative for malignancy. Berard's 1 is negative for malignancy, I'm telling. There is a lesion. It may be a fibroadenoma, right? This is all for malignancy.
Okay, sir.
Okay, so 1 is negative for malignancy. 2 is benign. It's a benign pathology. There is a tumor, it's benign. Okay.
Okay,
And
sir.
as we grow higher, it is definitely turning into malignancy. 4 and 5 is definitely malignant. Okay.
Okay, sir. Thank you.
Yeah. So next question comes, when we should use the other modalities, ultrasound and MRI. 1 minute. Okay. So when we will use the other investigations like ultrasound and MRI. If the patient is less than 40 years of age, if the patient is a pregnant, to differentiate between a solid and cystic lesion. These are the 3 indications for ultrasound examination. Okay. Someone is answering, why less than 40?
It's because it's dense tissues and glandular breast, and it is very and because of the sensitivity of mammogram, it's very low if you have dense tissues.
Yeah, dense breast tissue. Young females have dense breast tissue, so it is less sensitive mammogram. So we'll go for an ultrasound. And why in pregnancy?
Mammogram is an X-ray, so it's contraindicated.
Mammogram is contraindicated in pregnancy. And to differentiate solid and cystic lesions also. A solid lesion, a cystic lesion. What is cyst filled with?
Fluid.
Fluid. Okay. A mammogram cannot differentiate between a cyst and a solid lesion. So it's always better if you feel on cyst, there is fluctuation on examination, if there is fluctuation, you can do a ultrasound. No need to do a mammogram. Okay. And then MRI. In some special cases, we'll do an MRI. What are the special cases? See here, there are 3 indications for MRI. One is implant, patient with implant. Okay. Which is the material used for implants? Anybody?
Silicone.
Silicone. Yeah, silicone gel is used for breast implant. So when there is an implant, mammogram and ultrasound cannot differentiate between implant and the lesion. So it's always better to do an MRI in these patients. And high risk patients are with family history or already had breast cancer. These patients are very high risk patients. So you should never miss a small finding in that. So in high risk patients, you will do an MRI. And local recurrence after surgery. You have done a surgery, breast conservation surgery. There are 2 types of surgery, MRM and breast conservation surgery, which we'll discuss, like partial nephrectomy and radical nephrectomy. In BCS, breast conservation surgery, if we do, and suppose after some times, there is a small recurrence. Okay. To identify that, we need to do an MRI. And to differentiate scar from mass, okay, that also we need to do a MRI to differentiate a scar. Okay, it's not easy to differentiate a scar. Once you operate, after few years, there will be breast scar. Okay, we should, breast scar also will be indurated. What is the meaning of induration? Induration.
Is it discoloration, sir?
No, induration is hardness. Okay, on palpation, if you feel it is hard, thickened, that is induration.
Okay.
A scar, sorry? A scar is hard, indurated. So if we have to differentiate between, a scar and a mass recurrence. Okay, so we have to do an MRI in such cases. Okay. So till now the investigations part is over.